And this is the introduction and a continuation of the concept of perfusion, but this is part B. We've been talking about what blood pressure is. Blood pressure is the measure of pressure exerted against arterial walls. The systolic pressure is the pressure exerted when the heart contracts. And diastolic pressure is the residual pressure during relaxation of the heart. Pulse pressure is the term defined as the difference between the systolic and diastolic pressures. The pressure within the cardiac cycle reaches a systolic peak and a diastolic trough that are measured and reported on the blood pressure. The difference between the systolic and diastolic pressures is known as the pulse pressure. And so here is an example where you have a systolic of 120 and a diastolic of 78. Simply subtracting 78 from 120 will give you the pulse pressure. So you should get an answer of 42 is the pulse pressure for that individual. Another term you should be familiar with is mean arterial pressure, or the MAP. This we will be referring to frequently throughout this course. Many of you have probably seen that on the Dynamap, for example. It's in parentheses. In the example below, 155/85, the mean arterial pressure is 108, and that's the number within parentheses. And actually, although you've probably been ignoring it up to this point, it is a very important number, especially as we talk about these acute illnesses and disorders that we encounter in critical care. So we're very much interested in knowing the patient's mean arterial pressure. It is defined as the average pressure in the arterial circulation throughout the cardiac cycle. It can be calculated using the formula MAP equals the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. So this will be very important for you to memorize, not because I'm going to ask you to write the equation for me, but instead you will need to calculate it on your own because you know what it is, how to calculate it, so that you can answer questions appropriately as we go forward in the course and on test questions, okay? So we need to be able to use this information. If you are given a patient's blood pressure, you can calculate the mean arterial pressure, and that's going to be significant in determining if it's a priority or not in addressing this patient. So in general, I would say that we are very good about watching our patient's blood pressure and writing it down or recording it in our observation in our charts. But we really don't pay enough attention to this very important parameter, the mean arterial pressure. That little number hiding off to the side of the monitor screen is very important. And why should we look at it? It reflects the hemodynamic perfusion pressure of the vital organs. Okay. In other words, it's going to tell you if your patient's vital organs are being perfused. Okay. We say that in order for our vital organs to be perfused, the mean arterial pressure has to be above 60 and above. Okay, a 61 is not great. 62 is not great. Okay, yeah, it's not below 60 now, but it's very close. Okay, so In our example here, 155/85, the mean arterial pressure is 108. Well, that's excellent. There's no problem there. It's almost always a problem when it's on the low side, not when it's on the high side. So we really don't pay much attention to an upper normal level, but we are very concerned about a lower, I wouldn't call it normal, but where we know that our patient's vital organs are being perfused. Okay, so when it falls below 60, that's a problem. When the kidneys are not being perfused, what do? We begin to see that they cannot clear nitrogenous waste from our bloodstream, and therefore we have an elevation in our blood urea nitrogen and creatinine levels. Okay, let's address the topic of peripheral pulses, which we also assess as nurses. Arteries are more elastic than veins, and this allows the arteries to alternately expand and recoil as the heart contracts and relaxes with each beat, producing a pressure wave, which we can feel as a pulse over an artery. Pulses are described as increased, normal, diminished, or absent. Scales ranging from 0, absent, to 4+ are sometimes used. Okay? 4+ is your bounding pulse. Understand that on that scale of 0 to 4, 2+ is normal. 1+ is diminished. 3+ is increased, and of course 4+ is bounding. All right, so all of you have taken your patient's pulse and you have graded the pulse, the strength of the pulse. So you should really know what a 2+ pulse strength looks like at this point. As we go forward and learn about other states, for example, shock states, the pulse may be diminished. Or, well, let's even talk about heart failure. It's very typical for the pulse strength to be diminished, or 1+. While I'm talking about pulses, I want to make sure that you know that if a patient does not have a pulse anywhere in these distal extremities, like it's absent, that's a medical emergency. Okay, it doesn't mean if you can't find it, okay, then it simply means you need to go get a Doppler and see if you can find the pulse. Okay, so you can also document Doppler positive if you're really having a hard time finding a pulse. But when a pulse is absent, you cannot find it with a Doppler, then that is a medical emergency. And that is your job as a nurse to notify, typically it will be the surgeon. Sometimes after vascular surgeries, then there can be a problem with perfusion. So if that occurs, remember that you must notify the surgeon immediately, and they will be there very promptly in that patient's room to see if you are indeed correct. Remember, it's not just about the strength of the pulse, but you also need to be assessing the temperature of the skin when a skin is not being perfused, and because a pulse perhaps is diminished or absent, then the foot, I'd say the foot as an example, becomes very cool. That extremity will become cool to touch and perhaps even cold. You also can look for color. Okay, an extremity that is perfused well is going to be pink. Okay, and if it's not perfused well, it's going to be pale or blue. So we have to take in all of these findings and making our assessment, and they should really go together. It's not like you're going to find a warm pink foot when there's an absent pulse. Okay, but again, I just want to reiterate that when there is an absent pulse, it is a medical emergency, because anytime there is a risk of loss of limb or function, it's a medical emergency. Okay? If you don't get your limb perfused, you're going to lose that limb. And this slide also shows you all the various places where we can palpate the peripheral pulses. So we frequently do that in the foot, so make sure you know the difference between a posterior tibial, abbreviated as PT, and a dorsalis pedis pulse, abbreviated as DP. Okay, here we have the actual scale for grading the strength of pulses. Remember, along with that, we want to inspect the skin and feel for any changes in temperature. Inspect for color, feel for temperature, coolness. Note the symmetry. We want to have both sides. The strength of the pulse should be the same on both sides. Another thing we can assess by palpating the pulse is the rhythm. Patients who have arrhythmias will have a different rhythm, as you can detect that through their pulse as well, especially AFib. It's not uncommon for you to feel for the pulse and you see that it's a very irregular rhythm, and that's most likely an AFib situation. So you can detect rhythm as well, and strength, which would be your volume and amplitude. So I'll say once again, it is in a medical emergency if they do not have a pulse. A pulse of 0 is a medical emergency because there is the risk of loss of limb. Anytime there is a risk of loss of limb or loss of function, then that's a medical emergency. You'll need to notify the surgeon. More than likely it would be the surgeon, or at least a physician, so that they can come and see if that is indeed the case. Now, there's a common vascular surgery. I'll introduce it here. It is the femoral popliteal bypass surgery. Okay, that's a vascular surgery in which they take a piece of vein and bypass these arteries, the occlusion that is there. And the patient comes to the room, to the floor, and you need to then assess perfusion bilaterally in the legs of this patient. Remember, the popliteal artery is behind the knee. So this is going to be very important for us to assess for perfusion distal to the bypass and compare it to both sides. If the surgical side is cooler and the pulse is diminished, that is concerning on the surgical side. So compare it to the other side to see if it's the same or diminished. Certainly if it is absent, you must notify the physician. Okay, here's more factors that affect the pulse in this case. Lots of factors. I think these are listed in your text, but there's many factors that affect a person's pulse. And I'll just read them for you. Age, gender, of course, those are things that we can't modify. Exercise will affect your pulse, and a fever, remember that. Fever, as we'll talk about later, will increase your heart rate. It's a hypermetabolic state. It increases your heart rate, and therefore it will increase your pulse. Okay. Medication certainly will affect it. Hypovolemia, so if they're, for example, dehydrated, then we would expect the pulse to be diminished. Well, the pulse strength would be diminished, but truthfully, the heart rate is going to go up. So it will be faster but diminished. Okay. And so stress as well can affect heart pulse. Position changes affect pulse. And also pathology, which refers to disease processes. Okay, you'll need to learn the auscultatory areas of the heart. That means where you will place your diaphragm of your stethoscope in order to hear the valves. Okay, because what we're doing here is listening for murmurs. And murmurs are turbulent blood flow across the valves. So this slide is showing you some advanced assessment in terms of listening for heart murmurs. If there is a murmur, turbulent blood flow across the aortic valve, you'll want to place your stethoscope where you see the A for aortic valve. Now get that, it's on the right side of the chest, okay, in the second intercostal space. That's because that's where you can hear the aortic valve turbulent blood flow best. Okay. I always thought that was kind of strange in the past when I would see a doctor listen to heart sounds and he would place his stethoscope on the right side of the chest. That was just, now I understand that because that's the direction that the sound travels. And then we have the pulmonic valve can best be heard again on the second intercostal space, but on the left side of the chest at the sternal border. And then if you come on down, you can hear the tricuspid valve if there is any murmur present. Okay, and you don't hear murmurs in a normal heart. So the tricuspid again is located there at the fifth intercostal space and by the left sternal border. And then a little further out, we have the mitral valve where you can place the diaphragm of your stethoscope. It is the fifth intercostal space and it is the midclavicular line. That is where you're going to hear any mitral regurgitation or mitral stenosis. Any murmur of the mitral valve would be heard here. Yes, you should learn this information. Okay, so make sure you learn that. This slide is here to show you a mnemonic that you can use to help you remember the order of the heart sounds when you're listening for murmurs. The mnemonic is ape to man because you can listen to the aortic and then the pulmonic, then the tricuspid, and then down lower to the mitral valve. I don't think it's a very accurate picture of where you place the stethoscope, so I'm not including this slide for that reason. I want you just to be exposed to the fact that there is a mnemonic that can help you remember where to place your stethoscope for the various valves in the heart. So I see in this picture, it looks like they're actually placing their stethoscope on top of a rib. So it's very important that when you do listen for heart sounds that you don't place your stethoscope on top of a rib because those sounds do not transmit through bone. So that's important. And the truth is, just as a kind of aside, is that you don't want to listen to heart sounds through gowns or clothing, okay? That you will miss things when you do those shortcuts. So it's important that we have the skin bared so that you can really do an accurate assessment of heart sounds. Okay, I'd like to introduce some perfusion terminology and some concepts as well. The word thrill is what we palpate, and when you feel a thrill, that could be good or bad, depending on where you're palpating. In the picture that you see here, we have an arteriovenous graft, and that you have studied in your renal unit, I'm sure. So in chronic renal failure, an AV graft is most often used for vascular access. And this graft is surgically implanted and connects the artery and the vein. But it does have problems sometimes. Infection can occur, clotting can occur, or a blood clot can occur. So we want to monitor for any complications to the fistula or graft to see if it fails. Because if it fails, of course, they'll need a new site. So what we do is palpate that area, and we want to feel a thrill. We want a positive thrill when we are assessing a site such as an AV graft or fistula, because that turbulent blood flow indicates that it is patent. Okay? And it's open and the lumen and the blood is flowing. Okay? However, we do not want to feel a thrill in other areas of the body when we are assessing the vasculature, because that would indicate turbulent blood flow as a result of a partial occlusion of a vessel. So we wouldn't want to feel it really anywhere else in a normal vascular assessment. Okay. And the next term is bruit. Again, with our AV fistula, we would like to have a positive bruit, or we should be able to hear with our stethoscope abnormal noise such as whoosh, 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 whoosh. Okay, that's not normal anywhere else in our vascular assessment. Okay, it is normal for an AV fistula, and you can record it, indicating that indeed it is patent. Okay, so positive bruit, positive thrill are great when you're monitoring an AV fistula or graft, but it is not expected to be heard or felt anywhere else in the normal vasculature. Okay, for example, when you're listening to abdominal sounds, bowel sounds, no bruit should be heard over the abdominal aorta. Okay, and the abdominal aorta should be without visible pulsations or bulging. Okay. Abdominal bruits reflect turbulent blood flow associated with partial arterial occlusion. If there is a bruit heard over the aorta, it suggests an aneurysm. How about if you hear a bruit over the epigastrium, especially with patients who have hypertension? This suggests renal artery stenosis. Okay, that is a blockage to the renal artery. And I have actually had a student who heard that, and she came to get me so that I could also assess that with her. And indeed, that was the person's problem. They had high blood pressure, and it was a result of the renal artery stenosis. So she heard this abnormal sound, as I just made. Whoosh, whoosh. She just had no idea what that could be. So that's why I want to introduce you to this term bruit. And also using the bell, the smaller end of your stethoscope, to listen to or auscultate for bruits. Now, how do we describe heart sounds? First, when we're listening to the heart, we will make the determination if it's a regular rhythm or an irregular rhythm. Of course, most people have a normal rhythm, and that is regular. But some people have a condition called atrial fibrillation, and their heart sounds are going to sound different. It's going to be irregular, and you're not going to hear lub-dub, 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 okay? It's an irregular rhythm. So we take note of that. Does it sound regular or irregular? The first sound, the lub that you hear, results from the closing of the atrioventricular valves. The second sound, dub, S2 occurs because of the closing of the aortic and pulmonic valves. These heart sounds are best heard S1 and S2 with the diaphragm of your stethoscope. The low-pitched sounds can be heard better with the smaller end or the bell of your stethoscope. Okay, and this is good for extra heart sounds because we will be learning that you can have an S3 and an S4 as well. And these are extra heart sounds. They can be heard best with the bell. Okay, a pulse deficit is another term you should be aware of. Occurs with dysrhythmias and congestive heart failure. Okay, so the pulse deficit is the difference between the apical rate and the radial pulse. In order for you to assess the pulse deficit, it requires two nurses. Okay, you need one person counting the pulse at the same time as another person. Okay, the nurse and anyone else who can help. And one person will be looking at their watch at the second hand, and they're going to count for a full minute. And they start at the same time. So one person will say, okay, begin. And they both count for 1 minute. Then they stop and they compare their numbers. Okay, the pulse rate in a normal person, there should be no pulse deficit. It should be the same when each of them finish their count. However, when we have patients that are ill, such as an electrical arrhythmia in their heart or a heart failure situation, there is a discrepancy between those two numbers. A lot of times when the heart is weakened, that pulse does not transmit, the most distal pulse doesn't transmit all the way. So we have a lower number in the distal pulse compared to the apical pulse. Okay. Okay, another thing that can occur in other situations with other diseases of arterial occlusions and things like that, vascular diseases, would be an unequal pulses can occur between extremities, and that can suggest arterial narrowing or obstruction on one side. Okay, let's talk about murmurs. A quick review: the heart muscle squeezes blood from chamber to chamber. At each squeeze, the valves open to let blood through to the next chamber. Then the valves close to stop blood from moving backward. In this way, the valves keep blood moving as efficiently as possible through the heart and out to the body, one direction. But valve disease occurs, and when it does, a valve doesn't work the way it should. If a valve doesn't open all the way, less blood can move through the smaller opening. If a valve doesn't close tightly, blood may leak backwards. These problems may mean that the heart has to work harder to pump the same amount of blood, or blood may back up in the lungs or body because it's not moving efficiently through the heart. So let's talk about this. Problems opening. The term we use to describe this is stenosis. Stenosis occurs when a valve doesn't open completely. The valve may have become hardened or stiff with calcium deposits or scarring, so it's hard to push it open. Blood has to flow through a smaller opening, so less blood gets through the valve into the next chamber. I like to remember stenosis as a problem opening because they both have an O in them. Now let's talk about problems closing. Insufficient valves or regurgitant valves have problems closing. So the two terms here would be insufficiency or regurgitation to refer to valves that have a problem closing. This results when the valve doesn't close tightly. The valve supportive structures may be loose or torn, or the valve itself may be stretched or thin. The problem there is the blood can leak back into the wrong direction through the valve. Now we have a scale to grade murmurs. Of course, I don't expect you, and nobody really in the hospital, unless you work in a specialty area, maybe as a nurse practitioner, really would expect you to grade the strength of the murmur. But I want you to be aware that there is a scale, and I will point out what you should know about it. Grade 1 is the softest sounding murmur, and grade 6 is the loudest. A murmur graded 4, 5, or 6 is so loud you can actually feel a rumbling from it under the skin if you put your hand on the person's chest. Okay. Heart sound assessments may reveal the presence of abnormal heart sounds as well, such as a murmur or even extra heart sounds like S3 and S4. I have highlighted grade 4 because I have seen questions in nursing related to what grade of murmur can you associate with a thrill, and the answer is grade 4. Okay, that's when not only can you auscultate and hear the murmur, but you can also feel a thrill. Okay. This slide is provided because I want you to be able to listen on your own time, unfortunately, because I'm recording. But I'd like you to listen to some of these murmurs from the different valves and the two different situations I have listed here. First, we have the aortic valve. Remember, we listen on the right second intercostal space, the patient's right chest, at the left sternal border. Okay, that's where you're going to hear this sound. And by going to these sites here, you can listen to them. Some of you are going to be really good at picking up these changes in the various murmurs. Others of you might struggle. I'll just say do the best you can. I'm not going to give you an audio question, but I would like you to access these YouTubes and listen to an aortic stenosis, and then also listen to a mitral regurgitation. Okay, one of them is where the patient has a hard time stenosis opening their valves, and mitral regurg is a problem with closing the valve tightly. So listen to the mitral valve regurgitation and the aortic stenosis. Okay, so let's talk about some extra heart sounds. Okay, S3 and S4 heart sounds are not routinely heard. They are typically associated with pathologies or diseased hearts. So heart sound assessment may reveal the presence of abnormal heart sounds, such as S3 or S4, or even a murmur. A pathologic S3, a heart sound that immediately follows S2, is called ventricular gallop. It results from myocardial failure and ventricular volume overload. And we see those things in heart failure patients, as well as S3 can also show up with mitral or tricuspid regurgitation. So again, I give you a website or YouTube where you can listen to that extra S3 abnormal heartbeat. And then we have S4. It is that fourth heart sound immediately comes before or precedes S1, and it is called an atrial gallop. It results from increased resistance to ventricular filling after atrial contraction, especially in conditions such as if a patient has hypertension, coronary artery disease, cardiomyopathy, and aortic stenosis. Okay. Now, although it's not often, but especially in normally in young patients, we can hear an S3, but it's not as a result of a pathology. Okay, but my focus here in this course is on cardiac pathologies that can result in these heart sounds of S3, S4, which are referred to as gallops. Okay, so this extra slide I inserted to make sure that you got all of that information about S3 and S4, extra heart sounds. Yes, on occasion, they could be normal, but we, most of the time, are not assessing normal patients, okay? Say the S3 can be found in pregnant women. Okay, I'm just going to mention it because nobody needs to freak out if they're assessing a pregnant woman and you hear an extra heart sound. Same thing with S4, could be normal if they're a triathlete, so to speak. If they're really physically fit, well-trained athlete, you could have an S4. It doesn't mean that they have any kind of heart problem. Okay. So typically an S3 will develop late in a person's life, and it's abnormal. And we see it with heart failure, and they're listed there. Other conditions such as mitral regurg, ventricular septal defect, and after a heart attack, it can appear. So certainly if you're assessing a patient who's just had a heart attack and they develop an S3, that would be significant that you would want to mention to the physician. The rhythm it makes is typically or historically, nursing students have described the S3 sound as following the same rhythm as when you say the word Kentucky. Kentucky. That last syllable is your S3. Okay. I personally have discovered this one that I like, and it's called sloshing in, sloshing in, sloshing in, because that also reminds me of what is causing that S3, which is frequently from fluid volume overload. Okay. And then we have the S4. Historically, nursing students have used the rhythm to describe it would be the word Tennessee, Tennessee, Tennessee. And so the first syllable is where the S4 sound comes in. Also, but I like this one, a stiff wall, a stiff wall, a stiff wall, because it also tells me when we hear the S4 sound is often when the ventricular wall is hypertrophied or very stiff. So those things can happen too as we age and with cardiomyopathies. So either way, you can go to some websites and try to listen to the S3 and the S4 sounds.